Thank you, Joaquin, because I think as surgeons it's so important to be data-driven, and that now allows me to talk about sort of real-life applications and practical applications of Elon, EDOF IOL. So we have a few clinical trials running, and I'm going to today focus on the retrospective trial because it's targeted to mini monovision. The prospective trial is just more limited and a bit stricter, targeted to plano. And it's binocular implantation, and I've used a toric IOL when needed. And the post-operative evaluation included at 1, 3 and 12 months, visual acuity at distance, intermediate, near, including defocus curve testing and contrast sensitivity testing, residual refraction and patient satisfaction or PROMs. So compared to the target treatment, refraction, the outcomes were very closely the outcomes were very closely bunched towards the plano. And remember that these were targeted to mini monovision, so there is a small proportion down in the myopic end. But really we're seeing at 12 months 94% at plus minus 0.5. And remember that this is uncorrected distance vision and corrected distance vision in the darker colour. So for the corrected distance vision, we have 100% of eyes at 6.6 and 80% of eyes at 6 on 4.5. And for the uncorrected mini monovision targeted eyes, we have 94% at 6, 7.5, 88 at 6.6, and 100% of eyes at 6.9. So the defocus of the Elon the defocus curve shows quite a broad range for this lens for the Elon, even though it's an EDOF. And this is the monocular distance corrected defocus curve, so it's quite broad at around 2 diopters. Looking at the intermediate and near results, and these are distance corrected results, we have 100% of eyes at N12 or better for intermediate, and 80% of eyes at N10 or better. And for near, the results are good for an EDOF, with 100% of eyes at N14 or better, and 93% of eyes at N10, N12 or better, and 73% of eyes at N8 or better. So that's quite useful because in the clinic you can show patients the vision chart and give them an indication of where they're likely to fall with their near vision. And then, of course, we're looking at mini monovision, so the intermediate and near results are even better, with intermediate 100% of eyes at N10 or better, and the same for near, and for near 93% of eyes at N8 or better. I'm now going to move on to the post-Lasik eye because this is becoming an increasing problem where we're going to be dealing with post-Lasik cases in our waiting room for cataract surgery. And these corneas are aberrated. We have challenges with IOL calculations. And these are the patients that specifically sought out spectacle independence. And they're not always suitable for a multifocal IOL. So in order to achieve spectacle independence, then an EDOF is a good option for them. And we have to remember that the world has changed. So this is 50 and 60-year-olds 30 years ago, the Golden Girls. And this is 50 and 60-year-olds now, as well as this. So we have to pivot and change our practice to what we were doing 10 years ago because the world is changing. And moreover, this is what people are doing with their spare time and in their retirement. So the average post-Lasik patient is 10 to 12 years younger than an average cataract patient when they present for cataract surgery, and they're more motivated for spectacle independence, and they have atypical corneal profiles. So as I alluded to earlier, there's more difficulty with the lens calculations. There's a higher chance of residual refractive error because achieving the target and the accuracy with the IOL calculations is more challenging. they're more likely to have visual quality issues and dysphotopsia. They're more likely to have dry eye because of their corneal keratorefractive work, and they can have weaker or irregular corneas. And it's not just a technical challenge for us, it's also a communication challenge, because often if they've had LASIK, then they've had that real wow factor, and you just have to temper that, because often they can be slower to recover after they've got a LASIK flap as well. And I really treat those like a corneal graft post-operatively. So now just jumping into 2 patient examples. Firstly, the post-myopic LASIK patient. And I'm just highlighting the spherical aberration because, of course, post-myopic LASIK, often we see higher positive spherical aberration. Of course, the cornea is usually positively spherically aberrated. And in this patient, the myopic ablation must not have been too high, and often we don't have the data. But it is still in the positive range, which is what you'd expect. So the reason I like using Elon for post-LASIK eyes is because it is neutral, and there aren't many neutral EDOFs available on the market, and most of them are negative spherical aberrating. So this patient had non-simultaneous cataract surgery with Elon, aiming for plano in both eyes. And the 1-month results in the right eye were pretty good. The near was much improved by 3 months with N6 and seeing 6 on 7.5 plus. And in the left eye, the near was pretty good, but we had a little bit of myopic astigmatism helping that. But the distance had improved by 3 months to 6.6 plus, with the near staying at N6, so that was quite pleasing, and that was a binocular result as well. For a post-hyperopic LASIK, and unless you're sort of accustomed with looking at post-LASIK eyes, it can be a little bit more challenging to tell whether they've had a hyperopic or myopic LASIK. And again, that's an argument for using a neutral spherical aberrating lens. This patient had a negative spherical aberration because of the previous hyperopic LASIK, so we wouldn't want to use a negative spherical aberrating IOL. So this is a 56-year-old emergency department nurse, very active. She had LASIK, ages ago, and as is often the case with hyperopic LASIK patients, had regression and enhancement. This was quite early on in the Elon journey, so we didn't have available the Elon for the right eye, so I implanted another lens, and the target was supposed to be for mini monovision, and I was aiming for minus 0.75 in the left eye. And the results were 6.6 for distance and intermediate N6 and near N5. And even though I had targeted minus, she ended up plano. And her main issue post-operatively, which we had to deal with, was the dryness, but she's thrown her glasses in the bin. What kind of arts and crafts are you doing? Are you threading a needle? Or?
Sometimes, on occasion,
yes.
Not that much.
Yes.
So
crochet,
I paint,
painting.
I do a lot of puzzles.
Yes.
And as in jigsaw puzzles with lots of little bits in it.
And
so all of that stuff I'm completely free of classes from.
Amazing.
Yeah.
So often we think about post-LASIK patients as really only being suitable for multifocal lenses, but I would encourage you to think about using an EDOF because it's also a softer landing zone, and there's a bit more forgiveness in the target because of the EDOF effect. There is going to be a continued increase of post-LASIK patients in your waiting room. And with the right formula, and I'm not saying that the calculations are easy, but it's worth it to achieve spectacle independence for these patients. And with the right communication and setting expectations for the patients in case you're not hitting the target and you're more likely to need an enhancement, it is possible to achieve excellent outcomes. And Elon EDOF IOL, it offers a balanced solution. So you get that extended range of vision with reduced dysphotopsia and is really well suited to many post-LASIK eyes.
So Alison, you've used so many lenses in your time because you are an early adopter. How do you feel about Elon in the current space of all the other EDOFs?
It's true. I think I've used every single lens, especially the EDOFs. Look, it is my go-to lens, and for a number of reasons. We've had good results, but the material and the technical side of things really does matter to me. And I'm often using a lens to match to the patient, and predominantly, particularly for the refractive cases, I'm not a one-size-fits-all surgeon. But the Elon is my basic go-to for a number of reasons, not just the results. So Banu alluded to the refractive index, and that's significant because in spectacles, a high refractive index material is great, but it's always combined with an anti-reflective coating. But we all know those patients where we can see the glint in their eye, or they ask about the glint in their eye, and that results from a high refractive index material, whereas the entire platform has a low refractive index, so we're not faced with some of those patients that would be really bothered by that. The ABI number we've discussed is very high, so it minimises the chromatic dispersion. The lens handles very well inside the eye, and that's not, the defining factor why I would use a lens, but there are a number of reasons, but apart from the visual results.
Right.
Alison, is it true or is it my wrong interpretation that with your Elon lenses, more number of patients got better near vision than intermediate? Is that right?
It is, and actually the intermediate results that we're presenting are probably better than what I'm presenting, and the reason why is we were using a near chart at intermediate, and so there's a crowding effect. So it's confounded the intermediate results a little, but it means that the intermediate results are better than what we're presenting here. Thank you for noticing that.
Okay, thanks.